in neonatology. Over to Dr. Manoj, sir.
Thank you, Amit. Chief guest of the day, Professor M.K.C. Nair, respected seniors, and my dear friends. Good evening to you all. It is with immense pride and heartfelt anticipation that I speak to you now as we gather today for the inaugural session of the Quick Review of Neonatal Practice for Doctors, or QRNP as it's called, a crash hybrid course in neonatology for practicing pediatricians and trainees in neonatology and PGs in pediatrics. This occasion is also special for us as we are proud to have with us Professor M.K.C. Nair, the doyen of neonatology and pediatrics, our past national president of both NNF as well as IAP, and the former vice chancellor of Kerala University of Health Sciences as the chief guest for today. Thank you, sir, for joining. Today marks not just the beginning of a course, but the launch of a transformative journey in our mission to bridge the gap between actual science and the way we practice this science. QRNP program was in fact conceived with a singular vision to reach the unreached and empower all those who practice in the periphery, the practitioners of neonatal care, with a concise, evidence-based insights that sharpen clinical judgment and enhance real-world, on-the-spot decision-making. Whether it's a fresh postgraduate, a seasoned consultant, or a nurse at the heart of an ICU, this course is designed to be relevant and accessible and impactful to all of them. Behind this initiative is a deep sense of collaboration and a team that made this project a reality. I wish to express my sincere gratitude to all of them. For the organizing team, led by its chairman, Dr. Rishikesh Thackeray, vice chairman, Dr. Tejo Pradapalati and Dr. Ravi Sachin, coordinators, Dr. Murali Raj and Dr. Vishnu Mohan, joint coordinators, zonal coordinators, and members of the committee. We have a large committee for this. Let me also thank the faculty team for their willingness to devote time for this project. I also wish to thank the state NNF chapters for agreeing to conduct the contact programs, which are the hands-on workshops at the end of online modules in all the states. And our esteemed partners, including Medtronic, for their logistic support. Their unwavering support and shared commitment to excellence has made this a reality. And finally, let me also thank my dear friend, our Secretary General, Dr. Amit Upadhyay, for being the lead force in the execution of this program. Friends, I'm sure all your collective energy and expertise will help shape this program, QRNP, into a national movement of neonatal empowerment. Today, I wish to congratulate all of you, every learner ready to embrace this course. Thank you. This course is actually a beginning. Today is the beginning of the various modules being launched in various states. So if those of you are not aware of this, please make them aware, ask them to register and make use of this opportunity. As we inaugurate this program today, let us also celebrate the spirit of progress, the shift towards hybrid and blended learning that we are seeing now in most of our courses, reflecting our adaptability and innovation while we learn, while we work. Let QRNP be more than just a course. It must become a reflection of our values, our dedication, our shared pursuit of neonatal excellence. Thank you so much. Let our journey begin today. Thank you. May I now request the chief guest of today, Professor M.K.C. Nair, to enlighten us with his words of wisdom and inaugurate this course. Over to you, M.K.C. sir.
Good evening, Dr. D.C. Manoj, President of the NNF, the Lelan Bharati, the incoming president, Ubadhyaya, the Secretary General, today's faculty, I suppose, Rishikesh Thakare, Ravi Sachin, all the NNF leaders. Only three things I have to say. Number one is neonatal practice. If you take the whole neonatal practice as a group, there are three main players. One, of course, the health workers who actually go and visit on the third day, on the fifth day, make sure that baby doesn't have jaundice. This you may think that it is a small thing, but actually it's a huge effort. The effort of government of India to reach out to the remotest area. So they are a huge group. We need to really empower them. Second, of course, is our general pediatricians who take the brunt of most of the neonatal problems in the periphery, and most of the parents will go to them first. And then, of course, the NICU, specialist neonatologists, as a specialty who practice high-end neonatology, along with the nurses who have been well-trained. Probably this is the only specialty apart from the surgical, the operation theater, where the nurse's word is taken very, very seriously. So that's a great thing. We have a good thing. So we have three groups working for the babies. I just remember, I'm also a methodologist. So I remember Richard Pito, who has done so much of randomized controlled trials. At the end of the day, he made a statement that more than all this, big randomized control trial that we do for proving something, what is more effective is doing a simple, large randomized trial of simple practices. For example, when to cut the cord, when to cut the simple, very simple. There's a difference of opinion. Just do no need for big randomization. Just group A or group B. Just do like that. And because the number is so large, there's no confounders, nothing. Everything will be taken care of. I think that is a great idea that we can do, because all the participants of this, if you plan something like that, all the participants can participate without thinking that they are doing a big research. They're not doing a big research, but the results, if you can collate, it will become a good research. So that's the second point I want to say. And third, we have government of India spent so much of effort and money on SNCUs and all that, not necessarily so much on NICUs. NICs more of a private effort, except few huge centers. It's a private sector or the corporate sector which has put in money for NICUs. Now, if you have a baby, now a lot of people ask the question, why is it that in the world, not only in India, in the world, disability has not come down? Actually, it's true. Disability has not come down in spite of all the best effort that we do. The reason is all those babies who would have died otherwise now are being saved, so that they may have vision problem, hearing problem, they may have problem with studies, they may have problem with, executive functions, whatnot. Unbelievable small problems. In fact, the whole world is coming around to an idea that even the psychosis that we talk, it comes later, may have a relation to low birth weight and preterm. So low birth weight and preterm is becoming so much important because we don't do prospective studies. We always go back and find out this must be the one, this must be the one. And just to support us, we do an odds ratio, say odds ratio is more than 2. Fantastic. We proved that they are related. They are related, but nothing more. You can't really prove anything unless you go forward. So that is another issue that I say. So then how do we go about doing it? The first 1,000 days of life. UNICEF, WHO, Government of India, everybody is talking about the first 1,000 days of life. So every neonatologist, whatever be his practice, her practice, should focus on the first 1,000 days, which of course is the womb, the 270 days in the womb, first and second year. Some people like to say first 3 years, then also is okay, but we must do that follow-up. Now, what is actually happening is any baby has a little hypertonia, Now, the tendency is to be referred to adult physiotherapists who have never seen a baby. You know, they are very good. If I have a problem, surely I will go to them. They are well trained for that. But they are not even trained for children. Forget about newborns. A whole system of, wrong practices is spreading in the community. I may be taken to task for saying this, but I have no problem about it. Because I am the person who actually initiated, along with our Calcutta friend, the RBSK program. But when he initiated, we never knew it is going to take such a turn that every therapist will become their own doctor. They decide everything. The medical person is, in fact, I was told in Kerala, there are people are, started sending money for referring the case. Who are we to refer to them? You understand my point. All this because we are not taking responsibility to see that you spend hours and hours in the nursery, NICU, trying to save the baby, but we leave them, left alone, nothing more after that. So I think the first 2 years we need to, surely after that the child has, cerebral palsy, has any problem, they should be sent to therapists. They are highly trained for that. I have no doubt about it, but not to do neonatology. In fact, one of my development therapists, when they were going to do, OTs were going to have a, therapy inside the nursery. They said, why don't you go and see 1,000 newborn babies before go for therapy? What does it mean? It means you are not seeing babies. You are not, even if a nurse working in the NICU is doing that, I can understand, because she has hours and hours of thousands of hours dealing with the small baby. So there are a lot of small things which the National Neonatology Forum should take it seriously. If we don't do, our fate in another few years will be like physiatrist, the so-called specialists for rehabilitation. They don't do surgery, so they are left with nothing. Everybody dictate terms to them. So I think we should not reach that stage. We should save the baby, as well as we should try to do the initial period, not every time, at least the first 2 years, because you also know that you have done something. It's not only important to show the output, the outcome also. What happened to my babies, that's very important. And the best thing that I do for all babies is that simple thing: 2 months social smile, 4 months head holding, minimum 8 months sitting, 1 year standing, and now we have added at 18 months. Make sure your baby has no communication problem, no socialization problem, and he is not in his own world. That will take care of autism to a great extent. This actually, I'm saying this because out of in a little sadness that all these years we have worked together, and I think our own leader is in a very high position. Vinod Paul is a high position. NNF should discuss with him, with him, saying that, are we going to lose everything to somebody else, or are we going to consolidate what a neonatologist can do? Of course, I can't do at this time sitting in Kerala without able to travel, but you people can, in Delhi, can do it. Discuss Vinod Paul. Nobody has contributed to NNF as much as he has done. So, in terms of policy matters, particularly in not necessarily only the advancement in neonatology, but in terms of policy matters, he has made very, very significant steps. And this could be another major, thing that he could be doing, so that NNF, the newborns, and we as a professional pediatrist will be saved from disgrace of people, sending you money for referring cases. That I think is a great thing that we should do. Thank you so much. I have great pleasure in inaugurating this seminar, or the whole series of teaching, and I congratulate NNF leaders for taking this bold step. Don't mind my words. I have just said it out of sometimes frustration, I would say, by how the things are going. Neither can I do anything about it now. So that is the whole issue. Thank you so much.
Thank you, sir. Very thought-provoking words. Thank you so much. Now, before we go into session, I would request a few of the NNF office bearers to speak a few words. Dr. Lalan Bharati, our president-elect, over to you.
Yeah, thank you, Dr. Manoj. Good evening, everybody. And I would also like to extend my happy breastfeeding week to everybody, because we are celebrated today. We just started today breastfeeding week. So it is really an honor and privilege to be here with you all during this inaugural function of this flagship program of the QNRP. I would like to extend my heartfelt congratulations to our visionary president, Dr. V.C. Manoj, Secretary Amit, and all the dedicated team for this initiative, Dr. Rishikesh Thakre, Dr. Rabi Sachang, and all other. And this program is aimed at reaching the unreached, as our president said. Dr. Manoj, your commitment to enhancing the neonatal care is truly commendable. I am confident that this course will be immensely beneficial to the pediatrician, postgraduate students, particularly neonatologists working especially in the remote area. So we are really privileged today to have with us our esteemed chief guest, MKC sir. Your presence here today and words of wisdom will definitely inspire all of us, sir. Thank you, sir, for your continued support and guidance. And we are grateful for your words of wisdom, sir. And we will work on that direction. Whatever you have suggested, we will definitely talk and discuss with the Dr. Vinod Paul, sir, for further activities. Today, we have pleasure of we'll be hearing our first speaker, Dr. Rishikesh Thakre, who has been aptly selected for this occasion. We all know him as a remarkable teacher and who used to make the complex learning very simple. So I encourage everyone, all the participants, to engage actively during this course. Your participation will definitely enrich the learning. And I also request all the participants to kindly provide the genuine feedback on this course, as your insight will help us to improve the content of this course and continue this course in the years to come. So my best wishes to all of you for the happy learning. Let us all continue to strive to ensure that every newborn receive the best possible quality of the care. So thank you, everyone, and thanks for giving me the opportunity.
Thank you, Lalan. Now I request our Vice President, Dr. Dinesh Toma, to speak a few words.
Thank you, Dr. Manoj. It's always pleasure listening to MKC, sir. NNF, we know, is a body which is quite different from many other professional bodies because it is a purely academic body, and we always promote academics in NNF. QNRP, QNRP is basically a extension of that only. It is something which, when I talk to some of my friends, this you should have done this much before, because it's a kind of crash course. They are all happy to be a part of this program, whomsoever discuss this program. And I think something that started in COVID, the blended learning is the way forward, because we'll be having series of lectures followed by the practical hands-on. I think this is a program which is going to be stay in NNF, and it's going to increase the visibility and credibility of NNF. And as suggested by Dr. Amit and Dr. Manoj, we must incorporate this program as a part of most of our state and zonal neocons. Thank you, and thank you. Looking forward to hear from the speakers of this program. Thank you so much.
Thank you, Dinesh. Now, I would also request our past secretary, Dr. Surendra Singh Bish, to speak a few words before we go into this.
So thank you, Dr. Manoj, and sir, namaskar, Dr. MKC sir. It's always a pleasure to learn those words of wisdom. Sir, it's not out of frustration what you said. It is your frustration is actually inspiration for us. So whatever you have said, in fact, this will ignite new work. This will lead the way for all of us to work forward. And as rightly said by Dr. Lalan, Dr. Paul will be approached. Dr. Manoj has already done so when during the handover even in the beginning of its tenure only. I think we are in the right path, and Dr. Manoj, with this quick review, Dr. Manoj and the attendees who are there, I must congratulate you all. Uh, Dr. Narang, who was our past president, said when the NNF was started in 1981, the first conference at AIM was attended by around 500 and more people. And that time, it's 1981, though there were only few trained neonatology that time. That means most of the newborn care was being, and always will be provided by general pediatricians. As such, and rightly said, sir, there would be this kind of programs which would provide not a crash course. I will not say that crash course. It will just a refresher course. So it will be they have learned it all. So it's just a refresh their course and find their confidence. And all of you, I know, I'm looking at the big names in the attendance list also, and I must congratulate you all to believe in NNF, as Dr. Dinesh said. NNF is going to support you, is going to support this momentum of improving newborn care in the country. And with the kind of leadership, and I'm amazed at the kind of thoughts which Dr. Lalan has evoked today and he has read through, he has expressed his feeling, and this shows the leadership, continuum of leadership coming forward. And thank you, Dr. Manoj, for mentoring Dr. Lalan to such heights. Thank you for preparing him for next year also. Thanks, Ravi, also.
Thank you, Surinder. Now, before we move on to the session, I would request our treasurer and vice chairman of the QRNP course to propose a vote of thanks, and immediately, because he'll be moderating the session, I can introduce the speaker and then let us delve into the session right away. I would request all the participants to interact, and then we can have we are going to have a novel session today. We are going to learn the essentials of newborn care through OSCEs. So that's a new way of, I mean, it's a very interesting way. I'm sure all of you are going to like today's session. So over to you, Dr. Ravi Sachan.
Thank you, sir, for providing the opportunity, and amongst all of you, the galaxies of the neonatologists. And it is my proud privilege to introduce with Dr. Rishikesh Thakre. And I am sure his name is well within the circle, and I think everybody is aware about this contribution in the neonatology and other than neonatology in various capacities. So I would like to invite Dr. Rishikesh Thakre. He is the chairman of this QRNP committee, and he is going to talk about and a very important topic, how the way of learning essentials of the neonatal practices in getting started through the OSCEs. So I think the OSCE is one of the best way of learning, because it has got some structured way of teaching, and that contribute to the transformative kind of learning. So once you have an evidence-based literature, and then how we are going to clinically transform it. So therefore, it is I think the more of it is a transformative learning. So Dr. Rishikesh Thakre, we would be happy to listen to you. I am sure the audience will be going to gain a lot from your insight. Dr. Rishikesh Thakre, please.
Okay, let me share the screen. Okay, are the slides visible?
Yes, Dr. Rishikesh. Please go ahead.
So shall I start?
Yes, please.
Yeah. Okay. Thank you so much, Dr. Sachan, and a very good evening to you all. It is indeed a pleasure and privilege to be here today for this function, and more so when we have our past president, Professor Dr. M.K. Nair. When he was the president, I had the good fortune to work as part of his executive board. And father of developmental pediatrics, if I have to say, simple lot of things which he laid down today are standard of care when it comes to identifying a deviation or a delay. And thank you, sir, for those words of wisdom for us. The program of quick review in neonatology is NNF action plan under the president, Professor Dr. V.C. Manoj. And we have his vision, which led to the formulation of this program through our team of experts. My sincere thanks and gratitude to him and to the NNF office bearers for giving us this opportunity to formulate and implement this program. So without much delay, let's get started with the learning process. Well, I see a lot of postgraduates and fellows who have joined today. My request to them would be to type their answers in the chat box so that the learning can become more interactive. Well, the objective of today's session is to sensitize you to the different ways in which OSCE questions will be framed when you appear. But more importantly, this is a good tool for self-learning and more importantly, to sharpen the clinical acumen. And with these words, let's see how we can make the most of this learning. Okay. Have a look at this baby. Okay, so what intervention do you see in this baby? You could type the answers in the chat box. Okay, what you find here is that this is newly born. Why do we say that this is a newly born? You can make out that the cord is quite fresh. This baby is having breathing difficulty, and you can hear the increased work of breathing and the intermittent grunt that this baby has. What intervention is happening to this baby? So you find that there is a face mask and there is a device which is applied to this baby. So this could be just a free flow oxygen which is being administered to the baby, or it could be a T-piece resuscitator. So if you have any of these answers in your mind, then you're correct. Okay, how would you monitor objectively? Now, you saw a clue here, the way by which you would monitor any such baby who gets oxygen or any respiratory support in the delivery room is to put this baby onto a pulse oximeter. And it will display the heart rate and the SpO2, which will guide your further interventions. What two contraindications exist for use of such a device? Well, if this baby has no spontaneous breathing, has apnea, has suspected congenital diaphragmatic hernia or tracheoesophageal fistula, all these, or the baby is in significant shock, this would be a contraindication for this intervention. Okay. And the last question was, what are the benefits of its use? Well, today we do know that this simple evidence-based intervention has immense implications, both short-term and long-term. And there is decreased need for intubation, decreased need for ventilation, decreased need for surfactant, decreased incidence of chronic lung disease, and less and more survival, improved survival. So that's how the simple intervention with a focused assessment can help you to become better. Okay. Have a look at this X-ray, identify 4 abnormalities, and name 4 mimics for this X-ray. if you could put in your answers again in the chat box, that will make things much easier. Okay. Whenever you are shown any X-ray, the first and foremost is to ensure that it is well centralized. And the way you make this is by ensuring that the spine and the clavicles form a T. What you find here is there is no T, both the clavicles are up, that means it's a rotated film. And you can see on both the sides, the hemithorax is asymmetrical. So your first abnormality you identify here is that it's a rotated film. Mind you, if you have a rotated film, refrain from further interpretations because you are likely to err in making a diagnosis. So whenever you have, so we have to just identify what are the abnormalities that we see here. Second is that you find that, look at the lung fields, you find that it's a bilateral disorder, it is a symmetrical disorder, it is a homogeneous disorder. So that gives you a clue to say that what kind of disease you are likely to look at versus if this disease is localized or it is asymmetric and there is no generalized opacification. The third abnormality you would find is that the air bronchogram is visible. Now, the presence of an air bronchogram does not necessarily mean that it is a pathological. Up to 2 divisions is appreciated normally. Beyond that, it is pathological. And then if you see, you find that there is a low volume lung, which is here. So you also notice that there is an endotracheal tube. It is just above the carina, so it's okay. There's a feeding tube, and it is appropriately placed. So what are the likely mimics? Now, whenever you get any symmetric generalized homogeneous disorder, think of a disease pathology which is affecting both the lungs. So the classical example for this is RDS. You could also get this in meconium aspiration syndrome. You could get this in pulmonary hemorrhage. You could get this in congenital pneumonia. You could get such a picture also with pulmonary hemorrhage. What it means is, do not make a diagnosis based on radiological features isolated. Make a diagnosis also looking at the clinical picture. So always keep in mind that you always should make a clinical correlation and not jump to a conclusion just looking at the X-ray. Okay, have a look at this video. This video is an electron microscopic video of an animal lung, and it is showing you some pathology. What exactly is being shown in this animal lung electron microscopy? So what you saw here are the alveoli. The alveoli initially, if you see, were collapsed, and then something happened which caused these alveoli to open up, and then they gradually opened up and they continued to remain patent. So what you have here is a depiction of how alveolar recruitment takes place. Okay. Now, what are the ways to do this clinically? Now, the way by which you could do alveolar recruitment in clinical practice is by application of CPAP, high flow nasal cannula, surfactant administration, or even high frequency ventilation, or by application of PEEP if you're using a ventilator. So there are different ways by which you can bring about alveolar recruitment. How would you assess the FRC clinically? By FRC, we mean functional residual capacity. So that's a clinical way by which you can depict that this alveoli are collapsed and there is increased reflection of it clinically. So how would you assess it clinically? So retractions. So presence of chest retractions tells you that the FRC is still inadequate. And name a clinical prophylactic intervention to prevent such a condition from taking place? Well, use of prenatal steroids to mother for all babies less than 34 weeks of gestation with threatened preterm labor is a way by which you could prophylactically prevent such pathology from taking place. So let's move to the next question. Identify the therapy given. So you find there is a mother and you find that there is a baby and the mother and baby are together. And so what do you think is the therapy which is being given here? So there are two therapies which are happening simultaneously here. One is skin-to-skin care, also called as kangaroo mother care. But the second therapy which is happening here is use of fiber optic phototherapy. Okay. Now, what are the two benefits of this therapy? So when you use the fiber optic phototherapy, you are able to continue to keep the mother and baby together. This helps establish breastfeeding, and continuing of breastfeeding also ensures warmth, and more importantly, the stress, anxiety, secondary to separation is taken away, and therefore this is a beneficial form of phototherapy from that point of view. What are the two limitations of this phototherapy? The two limitations here you can easily identify that there is a fiber optic pad. So if you have a large baby, the pad will be smaller. So this is applicable only up to a particular size baby only, not applicable to larger babies. And the second drawback of this equipment is it is a conventional form of phototherapy. It is not an intensive form of phototherapy. So if the baby falls into criteria of bilirubin in the phototherapy range, especially if you are using the AAP charts, mind you, the AAP charts recommend use of intensive phototherapy and not conventional phototherapy. Okay, what co-interventions are happening simultaneously? One is skin-to-skin care, the second is breastfeeding. So these is simplest form of phototherapy, but if resources permit, one can easily put in regularly. Okay, so identify the skin lesion. What confirmatory test would give you the final diagnosis? What is your drug of choice? And how long would you give IV and oral therapy for this disorder? Now, mind you, again, your answers in the chat box are not coming. Okay, so mind you, this is umbilicated vesicles with surrounding erythema. So this is a classical picture of skin manifestation of herpes simplex virus. How would you confirm? By means of viral culture, but more so by PCR or by means of herpes simplex virus PCR DNA. What is the drug of choice? The drug of choice is acyclovir. Now, this point is very important. How long to give therapy? Remember, this herpes simplex virus infection in the newborn can come as an isolated skin infection, or it can come as a disseminated infection, or it can come with meningoencephalitis. Irrespective of the form, this is one of the few therapies where you need to give an extended form of therapy. So this is one of the few disorders in the newborn where you would have chronic therapies being given. So IV therapy at least for 14 days, but more importantly, you need to give per oral therapy for at least 6 months to ensure that there is complete eradication. Otherwise, recurrence is likely to happen. Okay, look at these diagnostic signs and tell us what the newborn has. So let's start with the first scenario. What you have here is a hypopigmented patch, and this is an in the form of a leaf. So this is an ash leaf spot, and that clinches the diagnosis of what are we dealing with. Versus this is an hypopigmented patch in rolls seen along the lines of Bushko. So again, this is a characteristic pathognomic feature of incontinentia pigmenti, which was previously known, but today is known as hypomelanosis of Ito. And mind you, this is present right from the early neonatal period, and such babies need a structured follow-up for cognitive outcomes, and so also are at risk for developmental delay and epilepsy. Have a look at the third baby. What you have here is that there is deviation of the mouth as the baby cries. But what you also should note are three things. How is the forehead? How is the eye? And how are the nasolabial folds? So if you see that the forehead is preserved, furrows, the eyes are well closed, and the nasolabial fold is preserved. So this is not a facial palsy. So this is what is called as absent depressor anguli oris baby. And inability to close the eye, absence of furrows, loss of nasolabial fold, these would go in favor of congenital facial nerve palsy, which is lower motor neuron facial nerve palsy. Mind you, though this has a good outcome, up to 30 to 40% of the time, such babies would have an underlying congenital anomaly, and all such babies should be screened for one, hearing, and second, congenital heart disease. Okay, look at this baby which is staring at you. And what is very clearly seen here is that the upper sclera is visible. So this is a setting sun sign. Now, presence of setting sun sign is physiological in the first 8 weeks of life. So don't subject all such babies to ultrasonography thinking that it is secondary to raised intracranial pressure. So this could be seen physiologically. What is expected of you is to monitor the head circumference and palpate the anterior fontanelle and look for signs of raised intracranial pressure. But an isolated sun-setting sign is not pathological. And lastly, look at this baby. This baby has a rash. This baby has hyperpigmentation, and this hyperpigmentation is classically in across the nose. And such babies come in crops. They have thrombocytopenia. They come with so-called sepsis-like picture, but the baby has poor feeding, decreased activity, and but the blood culture is sterile, and you find that the baby recovers quickly in another few days with supportive care, and the rash itself is diagnostic. And you ask for history of the mother, and they say the mother is admitted with inability to walk, with severe pain. So that clinches the diagnosis. So this is congenital chikungunya, and they usually come in epidemics. But keep this phase in mind, the hyperpigmentation, which is very classical, and it is such that the baby itself gives you a walking, talking diagnosis. Okay. Okay. Name a surgical emergency without abdominal distension and with no bilious vomiting. So we know we suspect a surgical emergency usually with distended abdomen or with bilious vomiting. But here we have a surgical emergency without abdominal distension. Okay. So mind you, the absence of bilious vomiting tells you that this is a obstruction somewhere above the second part of the small intestines, and it could be esophageal atresia, it could be gastric atresia, or it could be duodenal atresia, or it could be a malrotation with volvulus. So you need to have a high index of suspicion whenever you have a baby who comes with excessive crying and has no abdominal distension, because these findings come up only when advanced stage of the emergency sets in. By what postnatal age does air reach all of the small bowel and the rectum? And how would you differentiate a high versus low gut obstruction? And what is the definitive test to differentiate small from large bowel obstruction? Okay, so by what postnatal age would you expect the air to reach the small bowel? At least by 12 hours, by 6 hours, and up to the rectum by 12 hours. How would you differentiate high versus low gut obstruction? So if you see 3 bubbles, it is a low gut obstruction. But if you see more than 3, if you see 3 bubbles, it is high gut obstruction. But if you see more than 3, it is a low bowel obstruction. And the test to differentiate small from large bowel obstruction is enema. Okay. And what is the diagnosis of this baby with the classical facial features who has come with acidotic breathing, stupor, tonic posturing, has alopecia and dermatitis. So you see this baby hardly has any hairs, and there is a huge patch across the cheeks. And to your surprise, it also has severe metabolic acidosis, raised lactate, but the sugar and ammonia are normal. So what do you think is the diagnosis here? Now, this is one of the inborn errors of metabolism, which has a therapy and which is essentially treatable. So you are talking about biotinidase deficiency. Now, onset of which symptoms suggest irreversible loss despite treatment? Now, remember, if there is hair loss, it will not, it will get reversed. But if you have associated hearing loss or change in vision, they are irreversible. And obviously, developmental delay, once sets in, is a point of no return. Now, what are other preventable or treatable causes of developmental delay? In addition to biotinidase deficiency, it's hypoglycemia, hyperbilirubinemia, galactosemia, and don't forget congenital hypothyroidism. Okay. So have a look at this baby. What is the sign? And beyond what age would you say it is abnormal? So is it normal or abnormal? Obviously, what you have here is what is called as a roving eye. Question is, till what age would you watch, and at what age would you want this baby to be referred? Okay, so this is roving eye. This is this is pathological if it persists beyond 3 months of age. Have a look at this. This baby has a thumb which is adducted, covered with other fingers, what is called as adductor thumb or cortical thumb. So till what age is it physiological? So this, if it persists beyond 4 months of age, it suggests an opomotor neuron lesion, and it is always pathological. Now, have a look at this baby. This is a little bigger child, but is showing you something which is abnormal. The baby's head is turned, the hand and the leg on the same side is extended. So this is asymmetric tonic neck reflex. Persistence beyond 5 months of age is pathological. And you have both the eyes in the midline. This is hand regard. And again, persistence beyond 5 months of age is pathological. So next time you have a baby on follow-up, look at these subtle clues, for they are they need a closer observation, but more importantly, they also need follow-up. And I think I will take this last question. Have a look at this baby. So what you find that this baby has abnormal movements. So we will call these movements as seizures. But remember, today, these are clinical seizures. But the gold standard for diagnosis is clinico-electrographic seizures. if they correlate also with the EEG changes, or they may be an isolated EEG changes, what are called as electrographic seizures. So we will make this diagnosis as clinical seizures. And these are multifocal seizures that we find. Now, what is striking feature? Now, whenever such a baby you are seeing, what is the definitive treatment? Now, remember, this baby has seizures. The point is not to treat the seizures. The point is to treat the cause of the seizures. And what is very striking about this baby is this baby has extensive icterus, which is extending up to the legs and staining also the palms and the soles. So this baby with extensive icterus throwing up a seizure tells you is showing you signs of bilirubin-induced neurological dysfunction. So what is the definitive treatment? The definitive treatment here would be to undergo exchange transfusion. What is a definite seizure, possible seizure, and a probable seizure? Now, these terminologies came with the new International League Against Epilepsy position paper with special reference to neonatal seizures. Now, anytime you have a seizure which is picked up on a EEG, conventional EEG, which is said to be the gold standard, we call it as definite seizure. When such a abnormal movement shows abnormalities on amplitude integrated EEG, or clinically, if the baby has focal clonic or focal tonic seizures, we will call them as possible seizures. And a probable seizure is where clinical phenomena which suggest a seizure, but with no associated electrical or on conventional EEG or amplitude integrated EEG. That is called as probable seizure. And what do you mean by seizure-free period for stopping anticonvulsant therapy? Now, again, the ILAE gave us clear consensus statement to say a 24-hour seizure-free period on conventional EEG is diagnostic to say that this baby is now seizure-free and now the seizures can be stopped in this, now the anticonvulsants can be stopped in this baby. So this is how the newer changes have, in the understanding of seizures, have helped us change our management. So since we have covered, I think, some basic questions related to OSCE, I think I will stop because the time of 30 minutes is done with. And if there are any questions from your side, please let me know.
Thank you, Dr. Rishikesh, for such an enlightening insight through the OSCE. So there are a few the questions in the chat box. Dr. Shirashi said wants, sir, why is shock and TF apnea is contraindication?
Okay.
In what?
The fundamental for giving any baby CPAP therapy is that it's a non-invasive form of therapy, and you need to have spontaneous breathing. A baby who is in shock has cardiorespiratory instability, and therefore it becomes a contraindication for CPAP. A baby with tracheoesophageal fistula, as you apply CPAP, there will be release of pressure which is being administered. So there will be no pressure which will be generated, and therefore tracheoesophageal fistula, diaphragmatic hernia, all become, or a baby who has no spontaneous breathing or intermittent breathing or shallow breathing are all conditions where you would not offer CPAP to this baby.
So thank you, Dr. Rishikesh, for explaining. It appears that one more question is there, and with low FRC, do we get a grunt also? It is asked by the Dr. Sailendra Kumar Das.
Yeah, so remember there are two clinical clues that are there. The first clue is chest retraction, the second clue is grunt. When we say chest retraction, we are talking about low FRC. But when a grunt takes place, that means it is a pressure which is generated across the closed glottis. So this is a way by which PEEP in the sense which is being generated by the newborn, trying to what you can say, open up the closed alveoli. So grunt is a marker to say it's an alveolar pathology. Chest retractions tells you that there is low FRC. And a
Okay.
strider, if there, will tell you that it's a high upper airway obstruction. So those are clues to you to identify the cause of respiratory distress in any newborn.
Okay, the Dr. Resi sends you the thank you for explaining. And another is Dr. Rishikesh, do you remember what was the third OSCE? And Dr. Piyush Jain wants to explain for that, if you remember, third OSCE.
How can I remember? Okay.
Okay, no issue. We move to
So,
the third. I think I request Dr. Piyush Jain to please be a little specific about the questions. You can post your queries in the chat box. I'll take it
so
next
the
time.
third question, the third OSCE was that of the animal lung showing alveolar recruitment. And we said, how do we recruit the alveoli? So we said there are number of options, and we also put a question to say that it can be done
Yeah.
easily by means of antenatal steroids.
Yeah, that I think that video is a short video depicts the recruitment and de-recruitment phenomena very clearly. So Dr. Siresi, once again, only CPAP is contraindicated in these conditions, or even TPs and bag and mask is also contraindicated.
Okay, so how do you deliver CPAP in the delivery room? By means of TPs. Now, TPs is a transient way by which you would want to stabilize this newborn. Now, remember the TPs again is for short period of duration and is not the equipment or a modality to be utilized for delivering CPAP at such stage, though it may be used to deliver positive pressure ventilation.
Okay, Dr.
But
Rishikesh, pertaining to this question again, one of the member wants to, if suppose we don't know any antenatal history of CDH or any ultrasound scan is available, so how do we go ahead with the resuscitation?
okay, very good. So if you have a baby who is depressed at birth, you go through the initial steps and you start with bag and mask. Okay. Now, as you start with bag and mask, 9 out of 10 babies we know would respond to bag and mask ventilation. Now, this is one baby who deteriorates despite bag and mask. That means the baby becomes blue as you start doing bag and mask. Now, if a baby deteriorates on bag and mask and becomes blue, that should be the first alarm bell that should ring in your mind that you are dealing with a congenital diaphragmatic hernia. So what are you going to do clinically? You are going to do ventilation corrective measures. So you do MR, mask reposition of the head. With that also the baby is going to be blue. Then you are going to do suction and you are going to do ventilate with the open mouth. So SO, you increase the pressure, the baby still deteriorates. The baby improves dramatically the moment you intubate. So that's a clue to you to say you are dealing with diaphragmatic hernia. Now, that's why the entire NRP algorithm begins with, as you reach the delivery room, ask 4 questions to identify, is it a high risk pregnancy? Now, those 4 questions would give a clue to you, because one of the questions there is, how is the amniotic fluid volume? Now, a polyhydramnios, there is a clue to you to say that you are dealing with congenital diaphragmatic hernia. And as far as tracheoesophageal fistula is concerned, remember, most of the times it will be asymptomatic in the delivery room. It becomes symptomatic there after a few hours as you start feeding, the baby chokes, or you find that there are a lot of secretions which start coming up. And again, the history is missed about the amniotic fluid in the mother. So in that situation, you would do the resuscitation as per routine.
Okay, thank you, Dr. Rishikesh, for explaining in a simplistic way. Another question is with relation to neonatal seizure. And one of the member is interested to know whether if the EEG facility is not available, is there any clinical criteria when to stop anti-epileptic drugs?
Okay. So, if you see the recent ILE guidelines, they clearly tell us that if the baby is seizure free for 24 hours or more, and more so if the baby has a clinical stable course and is neurological normal at the time of hospital discharge, you would stop the anticonvulsant.
Okay, thank you. I think when to stop an anti-epileptic drugs now, it is very much available in our Government of India guidelines. Also, FDNC guidelines are there, so we can stop there. And if pertaining with the same question, then again the further question is, if the EEG is normal but activities are like cycling, or you may be so the neonate may be having some twitching of fingers, or some subtle kind of seizure if it is still persisting. So in that case, what we do?
Okay, so first and foremost is that you are dealing with abnormal movements. Ensure that your conventional EEG that you have done is being interpreted and reported by an appropriate authority, not by an adult neurologist. Most of the times you will find those making an error. If you are in district hospitals or smaller places, most of the times still we find psychiatrists reading the EEGs, which again will give you errors. B, look at the general well-being of the baby. Look at the sensorium and tone. If the baby is otherwise well, look for other causes beyond epilepsy. So, and if the baby is otherwise neurologically normal, keep a track and follow up this baby.
Okay, thank you, Dr. Rishikesh. With the relation to these neonatal seizure again, so one of the member is Dr. Jalil wants to know if on follow-up, if at the 3 months of age, if the baby appears EEG appears to be normal, but it still has got some neurological abnormalities, during clinical examination. So how do you approach that?
Okay. The ILAE again clearly states that the gold standard for management of neonatal seizures, and today they say that the anti-convulsive therapy or anti-epileptic drugs are to be given only if you have a diagnosis of epilepsy in mind. Now, that is only confirmed by means of an abnormality on the EEG. So, if the EEG is normal, irrespective of the neurological findings and the MRI, the current guidelines tell us to stop the anticonvulsants.
Okay, thank you. I think the last question is first line anti-epileptic drugs and the second line anti-epileptic drugs. So, Dr. Rishikesh, can you please throw some lights on how to select a first line and second line anti-epileptic drugs?
Okay, so again, if you go through the ILAE position paper, the first drug of choice today remains phenobarbital. Okay. The
Okay,
second drug of choice may be phenytoin or levetiracetam. Okay. And levetiracetam becomes the first line only if there is a possibility of, if there is a baby with congenital heart disease. Okay. Otherwise, the standard of care would demand that we would use phenobarbital as the first line of therapy. And if there is no response, move to the second line in the form of phenytoin and or levetiracetam.
Okay, thank you, Dr. Rishikesh, for explaining such a complex situation in what we are dealing in a day-to-day clinical practice. So in a very lucid way, and as Dr. Lerner already said, you made a very complex teaching in a simplistic way. Thank you so much for sharing with your valuable opinion. Now I request our President, Dr. VC Manoj sir, to please take over. Thank you, sir. Thank you. Dr. VC Manoj sir. Dr. VC Manoj sir, over to you, sir.
Am I audible?
Yes, sir, I audible. Please
Sir,
go ahead.
audible.
Okay. In between, I lost network. That's why. Yeah. So we are coming to the end of today's session. Once again, Thank you so much. First of all, our chief guest, MKC sir, for staying on till the end, and all of you and the delegates for being here. And then let this be a beginning. And also let me thank the speaker for today, Dr. Rishikesh Thakre, and the moderator, Dr. Ravi Sachin. So with this, we come to end of today's lecture, but this is just the beginning of the course. This course is different from other courses in that it's not happening all at one go. It's happening in different batches. That's why, some people are, in some states, like we begin with Delhi on 10th of, the contact program in Delhi is on 10th of August, and then it stretches the first 20 states which are hosting. The last one is going to be in the second half of November. It's going to be spread out. So please contact your state office bearers when they are hosting. You may attend the program along with your state or along with a neighboring state. It's up to you. Online module is, you need to hear the lectures and answer the questions. And once you complete that, we have the contact program. That is the second part of the course. And once we complete both, you get certified. This is a module. And please feel free to ask the NNF office for further details if you have any. Thank you so much once again, all of you. With all your permission, we'll close today. Thank you.
Thank you.
Sir. Thank you. Thank you. Good night, sir.
Thank you. Excellent.
Good night.